So one of the things with that we've kind of mentioned, but in passing, with any dystonia, but especially blepharospasm, is that you get this negative feedback loop between what the cornea is doing and how irritated the cornea is, and and how that affects the blepharospasm. And we all know, as Dr. Lau mentioned, that you have the medical student disease, which is that lower lid myokymia, and very often it's thought to be because of ocular surface disease. The eye is irritated, and you get this twitching, and once finals are over and you've passed your exams, and you don't have to stay up till 2 o'clock in the morning, that gets better. And that's certainly true in blepharospasm, where if you have dry eye from the get-go and an irritated cornea, that makes your spasm worse. Then we all of a sudden go and say, you know what we'll do to treat your spasm? We'll make it harder for you to close your eyes. And guess what happens? The dry eye gets worse. And again, you have this feedback loop. So I think this next lecture is extremely important for the adjunctive therapy. If you don't keep the eyes moist, if you don't keep the cornea clean and comfortable, your spasm will be worse. So our next speaker is going to be Dr. Kanesa-Thasan. He was a Wills resident, went down to do his cornea fellowship at Bascom, and is now back at Wills dealing with a lot of corneal pathology. We see a ton of corneal pathology at Wills, and it's great to have him back at Wills.
So my name is Dr. Kanesa-Thasan. We're going to be talking about coping with dry eyes and photophobia, and as it's been alluded to throughout today, there's going to be some exacerbation of both conditions between themselves. And so we're going to talk about how we can treat both the blepharospasm and dry eye and have them be successful. So I'm one of the cornea specialists and surgeons at the Willis Eye Hospital. I see patients downtown as well as in Paoli, and then I also do regular eye exams and cataracts. So I've seen a whole spectrum of dry eye in patients, of all sorts of types, and we'll talk about dry eye in general first and go over some terms so that we can work off that, and then we'll talk specifically about dry eye and blepharospasm. So I don't have any financial interest to disclose, and I won't be talking about any off-label use of medicines today. And as always, this talk is for informational purposes, so if you have specific questions, I suggest you talk to your eye doctor about your particular treatment plan, because we'll talk about how unique it is for everybody. So we're going to start with dry eye basics, learning the terminology, and then dry eye and blepharospasm in particular, and then we'll talk about treatment, what we can do about it. And again, this is kind of the outline. So we'll talk about dry eye and blepharitis, ocular surface disease and how it exacerbates blepharospasm, treatment options, how to manage the temporary lagophthalmos, which is that eyelid opening that can sometimes happen after Botox, and then I'll touch briefly on photophobia. So basics of dry eye. So this is the definition of dry eye from something called the TFOS DUES-2 report, and that's a lot of letters, and all that means is a panel of really bright doctors got together and talked about dry eye and tried to come up with something that encompasses all of it. And in encompassing all of it, you get a very, very long sentence. So they came up with dry eye as a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms and some other stuff. And I highlighted what's important, which is it's multifactorial, meaning there's many causes. Loss of homeostasis means there's a natural balance in many processes in the body, and the tear film is one of those. And we lose that in dry eye for a number of reasons, which we'll talk about. And it's accompanied by ocular symptoms, which is why we really care, because if it doesn't bother you, then we don't have much to talk about. But this is what brings us into the office, and this is why patients come back time and time again for treatment. So this is my plain English definition of dry eye, which is dry eye can be caused by many factors which disrupt the normal balance of the tear film, resulting in ocular discomfort. And then you don't have to fill out the extra words for your English essay. This is a slide from their report. Again, this kind of just outlines the complexity of dry eye. So I'm going to take you down the pathway that you care more about, which is presenting patient. You're usually symptomatic. Otherwise, again, we don't have as much to talk about. You're having signs of ocular disease, so there's things to be seen on the ocular surface that we can address. There may be some questions that your doctor asks of you to try and figure out how they can help you best. And that takes us to the diagnosis of dry eye disease. So we've already kind of bypassed many other pathways that we don't need to worry about in this stage. At the bottom, you'll see something called aqueous deficient, mixed, and evaporative. And we're going to talk about those. Those are how we describe dry eye and break it up for us to better think about it and better tailor treatments to you. And then at the bottom, you can see management to restore homeostasis. And again, we'll get into that. That's the treatment. And again, that needs to be somewhat tailored based on the types of dry eye that you have. So the spectrum of dry eye. So again, we're talking about aqueous deficient and evaporative and anywhere in between. Aqueous deficient means low production of tears. And so that's what most people think of when they think of dry eye. And I didn't say this before, but I tend to not like the term dry eye. I know I'm using it again and again in this presentation, but I don't find it as the most useful term to use. I find it kind of a bucket term that lumps a lot of symptoms in, but doesn't really describe what patients feel. And oftentimes I'll get patients tell me, "Doc, my eye is tearing so much, how can they be dry?" And so I like the term ocular discomfort or tear imbalance because I think those represent more what's going on for patients. And the other part of, if not aqueous deficient, evaporative means that the tears are evaporating rapidly off the ocular surface and not protecting the layer of the outer layers of the eye. We need our tears, like we've been talking about, our eyelids are the windshield wipers and the tears are almost like the washer fluid. So you need that to be covering all parts of the eye, otherwise the eye is going to start feeling uncomfortable and you're going to have pain, breakdown, inflammation that we're going to go into in just a second. So the vast majority of dry eye is actually evaporative, which people don't realize. Like again, most patients think, oh, my eyes are dry because I'm not producing enough tears. Honestly, it has a lot more to do with the quality of tears for most patients, but there's a lot of overlap. And so that mixed component on that last slide is very important. Some definitions, and I know this slide is very busy, but these words may come up later on, and so I want you to know what we're talking about. TBUT is tear breakup time, and that's the amount of time it takes for the tears to evaporate off the surface of the eye. If any of you played a staring contest with me, at some point your tears are going to evaporate. The question is, are they going to evaporate before you blink next or after? And so when tears are evaporating before your natural blink, that's where symptoms start and where things break down. But the natural amount of tears should stay at least stable on the ocular surface for over 10 seconds. If it's less than that, then we have a problem. Tear osmolarity has to do with the amount of components of the tear, salt, but also other things like proteins. So if you remember high school chemistry, osmolarity is the amount of solute that's dissolved in the solvent. So in this case, water, and the solutes are multiple components in the tear, not just, like I said, not just electrolytes, but also proteins and mucus and all their things that are natural parts of the tear film. And tear osmolarity measures how concentrated the tears are. So higher numbers of tear osmolarity mean that there's not as much water in the tears. The tears are very concentrated, versus a low amount of tear osmolarity means that there's extra water in the tears, so to speak, and the tears are very dilute. So tear osmolarity, it will come back to, but that's a good marker of dry eye disease. And the tear film, we've already alluded to, this is the layers of tears that covers the ocular surface, and this needs to be robust and protective of the ocular surface, otherwise it's not doing its job. And there's some controversy about this. People used to think there's a 3-layer component to the tear film. Now there's more accepted that there's a 2-layer component to the tear film, an oily layer on the outside, and then a mucoaqueous layer, which is mucus and water, and those are natural components that are being produced on the eye, on the eyeball surface. And the oil component mostly comes from the meibomian glands, which are lining the they run within the eyelid and they end right at the eyelid margin. And that comes back to blinking as well. But if both of those are not in balance, then we run into problems, and we'll go over that. This is a really busy slide. Make sure you memorize it. The test is coming afterwards. This is from the TFOS report as well. And I find it, I find it hard for me to understand, especially before lunch. So I redid it, and I think this will be more helpful. So we already talked about aqueous deficiency, again, low tear production, and evaporative, which is early evaporation, and the spectrum in between. And then we have some risk factors. So aqueous deficiency, what brings us there? Things like autoimmune disease, refractive surgery, reflex block. For example, if you have damage to the nerves around the lacrimal gland, then it's not getting the signal to produce more tears under certain situations. And some medications we talked about, anticholinergics and others, those can lead to decreased tear production. But like we've talked about, that's not the vast majority of dry eye. What goes into evaporative? Things like low humidity, high wind or temperature. That's why avoiding fans, avoiding direct AC in the eye can sometimes help. And meibomian gland disease, that goes back to the oils being thick and not flowing well and not protecting that oil layer on the surface of the eye. Both of those, however, lead to tear osmolarity, so highly concentrated tears, an increase in tear osmolarity. And that's why tear osmolarity is a great marker for dry eye disease, because you can test one thing and no matter what the cause, it can show, it can kind of lead you in the right direction. Why does this cause problems? So it's been shown that tear osmolarity causes an inflammatory cascade. So this was a lot of the letters on that last slide. And that leads to surface breakdown, which then leads to more tear film instability, where the tears are not covering the surface well, and that goes back to tear hyperosmolarity. And so this cycle kind of goes on, and it's almost Halloween, but this is probably the most vicious cycle that you're going to note. So how do we diagnose dry eye? And these are some things that your doctor can do in the office. Ask you about your symptoms, so tearing, burning, itching, light sensitivity, redness, intermittent blurring is very common. So as people read, they may notice things start out okay in the beginning, but then they kind of blur, and I blink and it gets a little better, but it's not perfect, and then the rest of my day is kind of shot, and that is very common. Signs like heavy, gritty, tired, people describe this in very different terms. And the hard part is the symptoms can be very variable. Many dry eye patients have some of these on one day, some of these on another day, combination of symptoms, no symptoms, or only one symptom. And so it can be hard on a symptom scale to know where people are. There are these screening questionnaires that can help you get there. So these are not specifically validated for blepharospasm patients, but the OSDI is one of the most common, Ocular Surface Disease Index, and it's 12 questions graded from 0 to 4. You can find them online, and a lot of doctors use this. There's also SAND and SPEED, which are just other questionnaires that ask about how you feel about the eyes, how often you have blur, those sorts of things. In the clinic, we can use some tools to help us as well. One is dye staining. So fluorescein dye is something that you've probably had exposure to. That's an orange dye that can be used. Sometimes it comes in a strip, sometimes it's pre-mixed in a drop, and you can apply it to the ocular surface, and it washes out over a few minutes, but what it does is it helps to highlight any epithelial breakdown. So we can see little staining spots with the blue cobalt light, and that's the top picture there. And you can kind of see, it may be hard to see from where you are, but there's some waviness on the surface there. And that also helps us see tear breakup time. So the dye highlights the tears, so instead of being clear, they're actually colored, and you can see when spots occur or when the tear film is thinning because the green fluorescence of the tears goes away in certain areas. Schirmer's testing is something that you also may have experienced. It's a small strip that's about 30 millimeters. It's a very thin paper, and it's applied kind of on the outside corner of the eyelid, and it soaks up the tears. It's almost like a coffee filter kind of paper. And we time from when we place it to about 5 minutes usually. Sometimes people run off the strip sooner than that, but the amount of tear production in 5 minutes is very helpful for us to know. You can do it with or without the anesthetic drop, and that can test how much reflex tearing and how much basal tearing there is. So there's multiple ways of doing it. I'll be honest, it's cumbersome to do on every patient with dry eye because it takes 5 minutes to do. And so not all doctors do this in the office. And often with just fluorescein staining alone and symptoms, I can get you, I can diagnose pretty well off of that. Other things that some physicians use are things like MMP9 testing. So MMP9 is a inflammatory marker that can be tested on the ocular surface. So by gathering a tear sample, that's that middle one in there. Actually, no, I think it's the bottom image there. It's almost like a pregnancy test. You can get a positive or negative on whether or not there's active MMP9 on the ocular surface. And the last one is tear osmolarity that we talked about. Again, there's testing kits that allow you to test tear osmolarity. There's costs associated with this, and not all offices offer it. And again, just with fluorescein staining alone and tear breakup time and symptoms, you can often arrive at the correct diagnosis. There are other diagnostics that can help us along the way. Topography is something that we use to map the surface of the eye, but indirectly it can show us when there's irregularity to the ocular surface. And in this picture, you can kind of see it's supposed to be projecting concentric, perfectly circular rings, and you can see there's some distortion there. This isn't a dry eye patient, it's just an example of what distortion we can see on topography. And again, most people don't use topography for this purpose. It's an indirect kind of side effect that we can notice if we get this map for someone. But there's a lot of dry eye, it can sometimes be very obvious. Epithelial mapping is another technology. Again, most offices don't have this, but this can kind of suggest changes in the epithelium that show patterns of dry eye. And the last one is something called meibomography, which is pictures of the meibomian glands within the eyelids and the tear function. And one of the major producers is called LipiView, which allows you to both see the meibomian glands and measure the lipid layer within the tear film. And so some doctors have that available in their office and use it on a regular basis. Again, kind of a fancy tool to tell you what you can often tell with other techniques. So let's talk specifically about dry eye and blepharospasm. So this is a paper by Dr. Liu and colleagues. I like this paper because it had a pretty large sample size of patients, and they compared patients with dry eye and blepharospasm against patients with dry eye alone against healthy controls. And so they had 40 patients of each, and they measured for all the patients the OSDI questionnaire that we talked about, the tear breakup time itself, Schirmer's test, fluorescein staining. They did something called impression cytology, where they basically press a filter paper against the surface of the eye and look at the cells, and then a cytokine assay, which is a wide array of inflammatory markers on the surface of the eye. And what they find is that patients with dry eye and blepharospasm had significantly higher inflammatory markers than the other two groups. And they measured these patients after Botox injection and found improvement in all patients. And the OSDI scores and the tear breakup times improved on average as well. And it was felt that the microabrasive effects of blinking and blepharospasm contribute to that feedback of dry eye symptoms, as Dr. Billick had mentioned and others earlier this morning. So going back to this slide, the theory is that in here, you're having another exacerbating factor. So the abnormal blink in blepharospasm is causing direct surface breakdown and adding to the cycle in another way. This is a slide from that paper, and the dark black bars versus the gray bars. So the dark black bars are patients with dry eye and blepharospasm, and the gray bars are the patients with dry eye. And all this just shows is that, in particular with photophobia, dryness, foreign body sensation, and visual fatigue, patients with blepharospasm had more severe symptoms in these areas, as one could imagine. This is a different paper that showed after Botox treatment effects on dry eye. So this was a smaller study, 16 patients. And in this study, all patients had relief of their blepharospasm with the Botox treatment. However, with the dry eye, it was kind of a mixed bag. So you had 3 patients where the dry eye improved, 8 with no difference, 5 with worse. And I suspect that this goes back to what has been already brought up today, which is there's variability in injection patterns and in response to injection. And sometimes you may have some lag ophthalmos, sometimes you may not. And, or there may be variations in anatomy that allow for improvement or worsening of dry eye. This is another paper where they looked at what's called higher order aberrations. And what those are is a objective measurement of visual blur And so higher order aberrations are not typically used for this purpose, but basically by shining in a light and measuring the reflectance out, you can see how clear the optical system is. And if there's a lot of noise in the data that you receive back, then you know there's a lot of higher order aberrations, which goes along with worse dry eye. And what this paper noticed is when they treated patients with Botox, they actually had an improvement in their higher order aberrations, suggesting that their dry eye had improved a little bit as well. And then they also tested with the standard mechanisms of Schirmer and tear breakup time and found that those were correlated with that improvement. So let's talk about dry eye treatment as well. And this could be, like other presenters have said, this could be its own 30-minute lecture. This could be its own conference. So we'll kind of do a 30,000-foot view of it. All of these are very individual, and I kind of liken this to a toolbox. I consider myself pretty handy, but if you handed me a technician's toolbox and told me to do their job, I wouldn't be able to. So just because all of these things treat dry eye doesn't mean that they're the right things for you. So having someone in your team who can pick the right tools for your specific case is critical. So just because you hear of newer treatments doesn't mean that that's exactly what you should do. And I often start patients at this level for all dry eye patients, and then I would assume the same for blepharospasm patients as well. Artificial tears can be helpful. What that does is it basically coats the surface of the eye, limits some of that noxious stimulus to the surface of the eye, and increases lubrication. Artificial tears aren't just saline. They're usually a variant of various petroleum derivatives. Some of them have a mucoid component. Some of them have an oil component as well, or emollient. So trying different ones can sometimes help you with that. There's specific ones that may be designed for, such as like Refresh Omega-3 or Retain MGD that might have kind of that more oil-centered component. Warm compresses help to activate those oil glands and get those flowing more. A lot of people do heat, but really you need to do 5 to 10 minutes because it has to penetrate into the eyelid, and then a little bit of pressure towards the end of that in order to get those oils flowing. I see a lot of people saying they're doing warm compresses, but they're really only doing 30 seconds or 60 seconds, and they're not putting any pressure on the eyelids. It's not really being very effective. And I would say that that helps a lot of my patients the most. Of all things, that's what a lot of my patients who have dry eye without blepharospasm find a lot of benefit from that. And that goes to the fact that a lot of dry eye in today's world is related to blepharitis. Eyelid scrubs can also be helpful, and again, that's kind of treating the area around the gland, so removing skin debris and what we call like collarettes or scurf on the eyelashes can decrease inflammatory burden there as well. And artificial tear ointments can be helpful at bedtime in particular, if there's some nocturnal lag ophthalmos, and specifically following Botox, we'll talk about that. Ointments can be helpful in general, although they do add some blur. And then environmental modification, I tell all my patients, when you're on screens, when you're driving, when you're focusing, you just tend not to blink as much. These are patients without blepharospasm, but after Botox, you also have the same limitations. You're not functionally able to use those muscles that we've talked about as effectively. And as Dr. Watson pointed out, you have a lacrimal pump mechanism across the ocular surface, so tears are being produced, and then the eyelid is gently blinking those across and to be drained. When you no longer have that apparatus working in a natural way, either in active blepharospasm or after Botox, then it's impaired to some degree. These are just going to touch on some moderate dry eye treatments. So when those first initial treatments fail, these are some things that we can turn to. And again, which of these we select depends on a very specific patient. But I just wanted to let you know that these are some of the things out there. Obviously, preservative-free artificial tears. I recommend these for patients who are using the artificial tears more than 4 or 6 times a day, because after that, there's a mild preservative in a lot of the bottles that can just kind of add sting to the surface of the eye. So if the ocular surface is already very symptomatic or sensitive, preservative-free can be helpful. There are several ocular surface anti-inflammatories that have been released that are really effective. You can do topical steroids, which is the third option. Those are things like Lotemax or Alrex or fluorometholone. Those are mild steroids that help to decrease inflammation in the short term, but they have long-term side effects. Things like cataract formation, eye pressure can increase, small risk of infection on the ocular surface. So for long-term use, the better ones are things like Restasis, Xiidra, Cequa, which are non-steroid medications, but they're anti-inflammatory in nature. Those take some time to kick in. In particular, Restasis can take 2-3 months or even longer for you to reach maximum effect. So if this is an issue and your doctor recommends it, I would start it and stick with it. It's not something that I would go on and off because you're not giving yourself the maximum benefit. Punctal plugs can be helpful in certain patients. What those do is those go into the punctal drainage system near the nose, and that keeps more of the tear film around. It doesn't allow it to drain as frequently. But again, that depends on whether or not that punctum is in place. If you have punctal ectropion, it may not be doing much to have a plug there. And if you're already having issues with tearing, then that can be exacerbated. So it has to do with particular patients. Things like omega-3 supplementation can be helpful. There's certain omega-3 supplements that purport to be best for dry eye. The evidence is mixed on some of them, so that some patients find help with that, some patients don't. And things like doxycycline or azithromycin, either orally or in topical form, can be used for blepharitis, both from an anti-inflammatory standpoint and an antibacterial standpoint, which is sometimes a component of anterior or posterior blepharitis. I won't really go too much into severe dry eye treatment, but just suffice it to say that there are many kind of higher level treatments for patients who do need it. Things like thermal pulsation, punctal cautery, which is like a permanent plug, essentially. Autologous serum tears, where you draw blood, spin it down, and turn that into eye drops for very severe cases, usually things like inflammatory dry eye. Amniotic membrane, I'm not a huge fan of for dry eye. It's very good for other things. Scleral or prose lenses are custom-fitted lenses that float over the ocular surface, and they can be filled with a number of things. It can be filled with autologous serum tears. It can be filled with protective saline. Some blepharospasm patients actually fill them with fluorescein and have found that to be helpful for photophobia. It's something that, you know, on the severe ocular surface disease spectrum can be used for protection. And then targeted surgical treatments. We've already talked about myomectomy. Sometimes this is outside the role of blepharospasm, but if there's any scarring on the eyelids or incomplete closure that's permanent, sometimes eyelid reconstruction with a tarsorrhaphy or lateral tarsal strip might be necessary. Again, our panel knows way more about those than I do, but that can be necessary to bring the eyelids in better alignment in order to improve their function long term. But again, those are specific cases and discussed with your treatment team. These are just some eyelid scrubs that can be used, again, in the setting of blepharitis. I'll touch quickly on treating lag ophthalmos after Botox. So we've talked about how the eyelids sometimes don't completely close after Botox injections. This is a picture actually of a patient with a facial nerve palsy, so I don't have the nice pictures that they have of all the lag ophthalmos patients, but you can see that the eyelids don't close entirely, and there's a little bit of ectropion there on the left side. So there's a number of options here. Again, it's a lot of the same kind of things, but we're just trying to make sure that we maintain the ocular surface. So frequent artificial tears can be used. Ophthalmic ointments are really good here, especially at night when you may not be able to control lid closure. Tape tarsorrhaphy is another thing. So tarsorrhaphy is a technique to use to mechanically close the eyelids. So some people can do that with just a small strip of tape, as that might be all you need. Sometimes what I tell patients is rather than tape one eyelid down to the other, is just to close the eye and put a piece of tape across the upper eyelid. And that's like a clear piece of medical tape. It's a little kind of like thick plastic tape. But what that does is it acts as a scaffold. And so even if you open the other eyelid, it keeps it from folding up under the eyelid, and that can keep it keeps it looking a little sleepy, but it does functionally work. And especially after Botox, if it's just temporary lagophthalmos, that may do you for long enough and be relatively, easy to do at home. Some people have allergy or irritation with the tape, and that can be a problem. Moisture chambers can help as well. You can find many of these online, but basically they're goggles that fit over the surface of the eye and help to retain moisture and prevent drying out of the ocular surface, especially at bedtime. And then in severe cases, glue or suture tarsorrhaphy can be used, putting a stitch between the eyelids, a temporary stitch that kind of keeps things closed, or we have cyanoacrylate glue, which is crazy glue, and we actually crazy glue the eyelids together in a very, very specific circumstance, and that lasts about a week or two. Again, hopefully we don't have to do that, and usually we don't have to resort to that in the setting of Botox, but I see patients who have more severe issues, trauma, burns, those sorts of things. Those patients need those, and I send those patients to Dr. Billick and Dr. Watson when I have them. This is an example of like a tape tarsorrhaphy, and again, you don't necessarily need to do eyelid to eyelid. Sometimes just applying it across the upper eyelid acts as a scaffold and allows it to close. Let's talk about briefly treatments for photophobia. And I'm honestly not the best person to talk about this, but from what I read, I'm sure everyone in this room is aware of FL41 tint, and there's a lot of evidence that backs that up, specifically looking at 480 and 590 nanometer wavelengths. 480 nanometer wavelength is in a blue spectrum, and 590 is in a yellow spectrum, and those in particular match up with the FL41 tint. And then this was another study that looks at FL41 tint that showed significant benefit over standard gray or rose tinted lenses. So there's some theory that that particular spectrum of blocking within FL41 matches up with the maximal absorption of the retinal ganglion cells, specifically the IP RGCs, and that is thought to be one of the major areas of photophobia for patients. And there's other cases, such as patients who've had issues with rod and cones in the retina, meaning they they can't see, they don't have any functional vision in those eyes, but they still feel photophobia, and it's because those ganglion cells are still intact. And so by aiming to block wavelengths that excite those areas, that can sometimes give you symptomatic relief. So in summary, there's overlap between dry eye disease and blepharospasm with evidence of two-way exacerbation of either disease. So blepharospasm exacerbates and worsens dry eye. Treatments of blepharospasm can trigger dry eye as well, and active dry eye worsens this cycle and adds worsening symptoms to patients who have blepharospasm. And Botox can significantly improve blepharospasm and in some cases improve dry eye, although we've seen in other cases it can add other challenges. And then the combined treatment of both can improve quality of life and restore function. So here are some sources, and that's all.